This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
A hearty welcome to all our listeners. My name is Michael Sorter. I'm the Chief Learning Officer at Laerdal Medical and your host at the 1 Million Lives podcast. Today's episode is a continuation of a talk I had with Professor Olle Ten Cate on assessment in healthcare education. I strongly suggest you listen to part 1 of this talk before going into this one. In part 1, we discussed how healthcare education is different from many other studies in higher education, in that assessment needs to be both helping us understand if the candidate is qualified to work as a healthcare professional, but then there's this second part to that, which is related to if you can be trusted to do the work that society has qualified you to do. It is this notion of trust and how we might go about assessing that we will be exploring in this episode. Towards the end of part 1, Olle said that we must ensure that there are qualities proven by science that assessors would need to look for when assessing a candidate of medicine or nursing during their clinical placement. And he suggested that some of these are reliability, integrity, capability, humility, and agency. I will get out of the way to let you dive right back into this very interesting discussion. And it makes all the sense in the world. I mean, from my education background, what you're saying, these are, in a way, they're probably also generic in a way for everyone doing a profession where you work with people. Of course, the way you apply them is probably unique to your profession, but I can easily relate to them in other domains. But let's now sort of try to get even more granular in the sense that I'm a medical school or a nursing school, and I'm really curious as to, or actually I may have decided to wanting to implement EPA as the way to assess students while they are in their clinical placements. Are there any particular sort of on a generic level steps a school would typically go through? I'm sure you've witnessed a few. So what would that look like from an implementation point of view for a school who wanted to implement EPAs?
I would say when you are as a group or a school or a specialty associations, that very often happens too, sometimes on a national level, think this approach sounds appealing. Now we need to start doing it. Of course, the first thing is identify what are those EPAs, and we have and it sounds like an easy question, but it's actually pretty difficult. But if you think of it, what is the activity that you would trust to do for a learner tomorrow? And you can just imagine that if you work in surgery, it might be different than would you work in internal medicine or in nursing. Those units of practice, you don't want those units of practice to be defined as very small, which is actually in early phases of implementation, people start coming up with sometimes over 100 EPAs. And if you would define all those EPAs and take them seriously and say, well, each of these EPAs need to be those components that lead to that important summative decisions from now you're ready to do this by yourself. And you can just imagine if you have that for 100 EPAs, it will not work in a program. So there's practical limitations to the size or the number of EPAs, which are related, of course. If you have more EPAs, the sizes are smaller. But if you have fewer EPAs, the sizes are larger. So in surgery, you could say, well, we can define an EPA related to the pathology. So you are ready to do this type of surgery for patients with this type of medical condition. In pediatrics, it might be that you would say, well, our decision for you to do something tomorrow morning might be running the outpatient clinic for common pediatric conditions. And then you will have patients coming to your clinic that have not been labeled yet. So you cannot use, for that activity, you cannot use diseases as an entity. Whereas in some surgery, you could say, well, there's a patient scheduled for surgery tomorrow morning with everything known, and the surgery must just be performed. So here's where a disease might be a unit for an EPA. So it is, and I won't expand because there's more ways to do that. You have to really carefully think of what are the EPAs, and we are seeing different research approaches to do that, and consensus approaches among people to come up with the best EPAs. Then you have those EPAs. Then when you start implementing them, you need to have a way to evaluate whether persons are ready to be doing that by themselves. So you need an assessment approach, and you need an approach that aligns with the idea of entrustment. And the idea of entrustment is usually framed in the amount of supervision a person receives. So you could have close supervision, you have no supervision, you have something in between. Here's where specialties also differ. So you could say in surgery, during at least intra, in the OR, you could see there's different shades of help that I can provide to someone who starts becoming a surgeon. But in internal medicine, it could be very different. You are not always close supervision as being present during the activity is something that even a first-year resident in internal medicine seldom actually happens, because they are working with patients just by themselves, and they are debriefing with her. So the skill that you would be using to qualify what is the level of supervision, what does that look like, might be different for different programs. So you have to have that framework too. Then you start working with educators who have been trained many years in their own practice and have been working with very different approaches to assessment. So you need to inform them well, and they need time to understand what it really means to be entrusting a learner. We say in working with EPAs, we make a distinction between ad hoc decisions and summative decisions. The summative decisions are those, I would say, qualifications that almost look like a license to practice without supervision. The ad hoc decisions are the things that happen every day, that if you are working with a new student and you are on a clinical workspace and you would say, well, maybe now I've seen you working yesterday, today I can leave the room because I think you will probably do well, but page me as soon as you need my help, or let me debrief with you right after your interaction with the patient to evaluate how you were doing. So leaving the room is an ad hoc entrustment decision, because you're trusting that the patient it is safe enough to have the patient just be interacting with you, with the learner. That are ad hoc decisions. So you need a series of those ad hoc decisions. But the thinking of clinical educators is very ingrained with our traditional way of making a score on a 10-point scale or a 5-point scale or whatever. So that is so ingrained in their way of assessing. So to have them think of responsibilities and entrustment is, I would say, a shift in thinking. And that is not always easy. So you might want to train people to do that.
And it's very novel, I think, but also speaks to what we talked about before about addressing patient safety and so on. So I really like what you're saying, but I can sense as you're talking, I'm sort of falling back into in my head at least, a sort of, okay, so what is then the difference between skills and entrustable activities? And you somewhat touched on it because you said it's not really viable, or you can't have 100 EPAs. I remember reading in one of your recent papers from 2022, and the paper is called, for those who want to search it up, Entrustable Professional Activities versus Competencies and Skills, exploring why different concepts are often so conflated. I'll put a link to it below here. But you seek to clear up some misunderstandings regarding the use of EPAs versus the use of more established notions like competencies and skills. I have struggled a bit with this distinction for myself, but you had a very interesting statement there. You said Clearly, one cannot possess EPAs nor become qualified for competencies. Rather, possessing competencies and being qualified for EPAs is the goal of medical training. Could you unpack that a little bit further?
Yes, it's good to do that because it happens very often. Many people actually struggle with that distinction. But if you think of EPAs of something that is on the work list in the hallway of a clinical department that say, well, we have so many patients, this must happen today, somebody must do it. You could see that all those activities are really units of practice that are not owned by an individual. I mean, they must be done. And then if you would be like the head of the ward of the department, you would say, well, or the one who schedules actually individuals for service would say, well, this person will have this person do that. And so the activity is not something that's inside the person. Now, competencies definitely only are inside individuals. Now, why are they conflated? And that is probably because it's not easy to even formulate what a competency is. People start, if you ask them what are competency frameworks and what are the competencies that people need to possess, then if you look at it, writers become lazy in the way they write, because they would say, well, of course, history taking, that competency they need to acquire. And now, wait a minute, history taking, is that a competency or is that an activity? It actually is an activity, that's clear. But it's a competency, but a competency is probably the ability to do so. And basically, I would ask a deeper question. So what competencies do you need to possess to do a good history taking? What are those competencies? And then you come to things like, yeah, of course, I can think of that. That's like, you need the ability to have professional behavior, or you need clinical reasoning skills, or you need to interact with a patient well. You need to organize things well, to have things in your mind. You need to probably know how to talk with a patient and work on your laptop or your electronic health record, because you're probably combining writing and talking at the same time. All those things that are skills that you need to do while you're taking history. Now, people just say, well, history taking, we call that a skill. So basically, linguistically, confusion arises. And you would actually have to say, if you call that a competence, it is rather the ability to do so. But it is a very broad ability that can be broken down into different skills and competencies that you need to do to be able to do that history. So I understand why that happens. Now, the reason why, if you start conflating that and say, well, EPAs, we call that just big competencies, there is a risk in that. And because you start losing the idea of entrustment decisions. And that's what I sometimes see happening and that was the article that you're referring to, is a little bit critical about those programs that say we make entrustment decisions for EPAs, but basically only say we would qualify you, but we're not actually making that decision. And here, it's not much different than making an evaluation of somebody's skill. You say you have the skills. We're not going to make that step that tomorrow you're allowed to do that without supervision, because we're not backing down on supervision, or we're not giving you more autonomy. So by doing that, and then the conflation increases, because it becomes harder to say, when you evaluate a person, is it just your skills that we're evaluating, or are we really making decisions about an activity that you're allowed to do?
And I think that makes it so much clearer to me. Thank you for that distinction inside the person or the activity you do. I mean, that's helpful. I think most people can relate to that. I guess it brings a question to me, and sort of, as you see it, working a lot with this, what are the limitations or potential pitfalls in the EPA approach that people need to be at least aware of if they want to go down this road?
If you want to use the full potential of working with EPAs in a program, summative decisions of entrustment and increased autonomy over time must be operationalized in some way. If you are in a program or even like a state or a country that had regulations that prohibit learners to work unsupervised or even with decreased supervision. There are regulations sometimes that would require, as long as a learner is even in postgraduate training, that there must be a supervisor in the room even. In surgery, it happens. In other domains, I have one of my PhD students was a gastroenterologist training learners with colonoscopies. And he said, I have many senior learners who I really completely would trust to do this by themselves, but I'm not allowed to leave the room because of the regulations. And if a patient, if something would happen, and the patient would say, was this learner alone, or were you there? Then they would not meet the regulation and regulatory things with danger for litigations or whatever. But at the same time, and I'm coming back to the thing that I said early in the interview, realize that if a person is licensed or certified to do those colonoscopies, the next day or right after training, there's no supervisor, not even like in the vicinity to help if you need help. Then for like superficially, a patient might think, well, this was not a learner in training, so I would have to trust it. But it is a false distinction also for a patient to think this is a trainee, so I cannot trust them. And that has been the narrative in many circumstances. And it's a dangerous narrative, actually. It prohibits programs to use the full potential of working with EPAs. So that's one of the pitfalls.
You're listening to 1 Million Lives, a Laerdal podcast.
I've been to the hospital and a person came along with a tag on the chest saying student or doctor in training or whatever. And I think in a way we are, as patients, then tend to be more skeptical. Why am I not getting the real deal or the best doctor in the ward or whatever? So I can relate to that very easily.
Yeah, so that's one pitfall. There are other pitfalls too, and I would say one of the things we touched a little bit upon. If you are working with EPAs, there's a tendency of programs to increase the numbers of EPAs, and if you have a very large number, your program is going to be difficult. If you want to install that, and you want to say, well, everybody needs to meet the requirements for entrustment, and we have to document that all, then documentation and observation may become a burden. And definitely learners need to be observed. Some decades ago, there was hardly any serious observation for learners. So that has to increase. And there's no way around that. If you work with EPAs or not with EPAs, that is some people call that a burden. If you really think about that, it is usually less burdensome than people actually think they are. I mean, they think, I'm a physician and I have a trainee, but I don't want to be distracted by my trainee. They can observe me and they will probably be. But if you're a serious educator, you have to really work with that trainee and observe them and teach them, provide them feedback. We do have technology coming up actually to make that more easy. And there's some good examples of that too. So the burden of assessment is sometimes what people also feel as a drawback. And I would say it's not so much of EPAs, but it's rather of workplace-based assessment in general, if you use EPAs or not use EPAs.
Can I tag along on that? Because when I came to visit you in the Netherlands, we met at a very famous simulation center, the Med Center, where I believe you are part of the supervisory board. And you brought up the potential of technology to be of help in doing EPAs. And I would sort of wanted, and maybe I'm putting you a little bit on the spot here, but how do you see the role of technology? And maybe we can even expand into, is there a role potentially for simulation, healthcare simulation in this domain?
Yeah, let me make a distinction of two types of technology. The one type of technology I just referred to in the previous question is the technology that is coming up using smartphones and mobile devices during workplace-based assessment. And there's examples now that related to EPAs, those evaluations can be made very quickly, just in a matter of 1 or 2 minutes. Actually, you can do that when you have that well organized with the right software. You could do it on the hallway, you do it in the elevator, you could do it very briefly during clinical training. That's one type of technology, and I think it's going to be important too. The other type of technology is actually preparing learners for activities in a simulated way. Now, simulation has, I would say, since the 1980s become very important in medical programs. And I think it is important. You want to minimize the harm to patients by preparing students well before they start doing work with patients. Now, that preparation can be seen as something that is completely outside the workplace, just as a preparation in courses and skills training. Sometimes I see increasingly mergers of that in situ simulation. Examples you can see where standardized situations are there where students have the benefit of being able to practice over and over again without harming patients or even like burning patients before they are ready to do that. So that technology is important and is increasingly coming up. Also, I would say moving closer to workplace-based assessment. There's one warning that I would like to give if you work with EPAs, that I believe that for almost all EPAs, just standardized assessment in a simulation environment would not suffice to certify or qualify a learner for working unsupervised if you have not done that also in true patient care and being observed, doing that with real patients, just because of the variability of all the components that are in a live patient care situation. But you can move and to quote what I think it's important for you to save lives by preparing students well with simulation. So I think it's very important. That's one of the reasons why I joined the supervisory board of a large simulation center in the Netherlands, because I think it is helpful. And that center is now actually this year, the first time they are focusing their simulation on EPAs. And that is actually even more dominant for them in nursing. Postgraduate nursing in the Netherlands is moving to completely EPA-based programs and very flexible EPAs that can be used for different specialties in nursing. And they're also being trained in simulation centers. So they are adapting their training to comply with the new framework of working with EPAs.
Well, and I think that's actually a brilliant topic for another talk, how that would pan out. And once you have some experience under your belt, I want to learn more. I really want to thank you so much for joining this discussion, Professor Olle Ten Cate. I hope our listeners found some golden nuggets in our discussion. But if anyone wanted to read more and what you have written and follow you, where would they go to find some of your publications?
If they're truly interested in my personal publications, of course, you can always go to PubMed and put in the word Entrustable. As you may know, the word does not exist in dictionaries, so it's pretty unique.
Should trademark it.
Yes, it makes it easier to find that. If you look for personal publications, which also include other publications than only on EPAs, I would suggest to go to my Google Scholar website in Google and look at the overview of publications and citations.
I will certainly make sure to include a few of them below the episode when we publish it. Thank you again so much. Enlightening. I've learned a lot. I hope the same goes for our listeners. And thanks for now.
It was my pleasure. Thank you.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.